Well, good afternoon, everyone. Welcome to the Independent Stage briefing, the Friday briefing. Now, when this COVID pandemic began, it's an understatement to say that the UK was not prepared. After a delayed response to the threat, the UK government did not devise or implement crucial suppression policies, nor an effective find, test, trace, isolate system to suppress new outbreaks quickly, and was very poor at responding to existing and growing inequalities among people. And this should, of course, not be the case. Now, there will be another pandemic. We just don't know when or which kind of virus will attack us. And many scientific and public health voices have asked for much better preparedness measures for when this comes, not just for the UK, but also taking a bigger global view. So how we lessen impact, respond rapidly, and protect the most vulnerable society is the subject of today's discussion. And we have two very special guests with us from the next generation, Helene-Mari van der Westhuizen and Dr. Tanvi Rai. And they are going to talk about how best to prepare for the next pandemic. But before that, I'm going to invite Professor Christina Pagel, our Director of IndySage FBI, that's Facts, Utards and Intelligence, and she will give us a presentation of the latest numbers and trends. Over to you, Christina.
Thank you. Right, so having promised my IndySage colleagues yesterday that I'd be really short because there's no more data, I found lots more data. So it might not be quite as short as I promised, but I think it is all relevant and interesting. And certainly some of it, including things like the state of the NHS, definitely does speak to pandemic preparedness. Right, so I'm going to start with vaccines. And the spring booster campaign has now started. It's targeted at the over 75s and immunosuppressed. And you can see really this is the week it really took off. This is the over 80s number of doses given. This is 75 to 79-year-old, and this is immunosuppressed. But there's still quite a long way to go. This is coverage per group, and you can see that no group is at over 20% coverage yet. So, but it has started, and that is good news. Now, going to say something about the latest hospital admissions and deaths numbers. But before I go into hospital admissions, I just wanted to highlight the kind of the changes in what testing has been happening in hospitals over the last year and what that might mean for interpreting hospital admissions, but also interpreting what happens within hospital infections, which count as a new COVID admission. So a year ago, in April 2022, there was no more testing for visitors to hospitals, and there was a big shift to use lateral flow tests instead of PCR tests for patients and staff. And it was also the end of free tests for the general public. And so what that means, I think, is that there was more likely to be people going into hospitals to visit who had COVID. In September 2022, most asymptomatic testing within hospitals stopped, and that was a massive difference, right? It used to be that every patient got a COVID test. That stopped unless you had symptoms in September 22, and also the regular weekly staff testing, asymptomatic staff testing, also stopped. So that means we would see fewer cases reported in the stats, and also there would be more COVID around in hospital without being spotted. And as of this month, they've stopped pre-admission patient testing. So it used to be if you were going to be admitted to hospital for surgery or an outpatient appointment, you would do a test. That has stopped. If people are transferred between wards in hospital, there's no testing for that anymore. And even now, healthcare staff who have symptoms of a respiratory infection, most of those are no longer asked to test for COVID either. So who is still tested? So still tested is anyone admitted for their COVID symptoms. Or anyone who develops symptoms in hospital, but only really if COVID affects their medical management. That probably is still most people, but this testing has been massively scaled back over the last year. So with that in mind, let's have a look at hospital admissions. So this is up to the 24th of April this year. So over this period, we've seen decreased testing. And I just want to say the reason I'm not showing a graph of decreased testing is because those numbers don't exist. we don't have the number of LFD tests and PCR tests carried out in hospitals. We are on a downward trend. This latest peak is definitely down and down quite significantly. So that is good news. We're kind of at the historical troughs. So we'll kind of see what happens next. But so far this year, so since January 2023, there have been over 87,000 admissions. And that's a minimum because, as I said, we're testing a lot less. And about 25,000 of those are people who caught COVID in hospital. And that is quite a high number, particularly because these tend to be much more vulnerable people who really would rather avoid COVID. In terms of deaths, this is the number of people each week in England and Wales with COVID on their death certificate. So COVID is judged to be on the causal pathway. And again, you can see we had a recent spike in March that is now coming down, which is good news. We've had 2 spikes this year, one in January and a smaller one in March. So far this year, there have been just over 8,500 deaths with COVID on the death certificate. And that is, it is a significant number, but I think we do have to acknowledge that it is a lot less than over that same period a year ago, which was almost 15,000 deaths. So there we are seeing fewer deaths now than we did a year ago, and far, far, far fewer than we did in 2021. So that we are making progress in that sense. But I do want to say something about the state of the NHS. We covered it a lot this winter when there was a really significant NHS crisis, or really a collapse of emergency care. We haven't really spoken about it much recently, but it's not all okay. So this is the percent of A&E attendances, people who wait longer than 4 hours from turning up to admission. You can see this big spike here. It was this winter when it got up to 35% of people waiting. The target is less than 5%, which we haven't hit in years, but this was by far the worst. But it's still really, really high historically. It's still almost 30% of people, and it's bumped up again over the last month. Waiting for treatment, we still have record numbers of people waiting for treatment. 1 in 8 people in the UK are waiting to start treatment. In England are waiting to start treatment. I mean, the only good news is that it's not still going up, but this is really unsustainable, and it's incredible backlog, and it will be causing a lot of stress and worry and illness to people who are waiting to have treatment. Here's an example from cancer. This is the percent of patients waiting longer than 2 months to start cancer treatment following an urgent referral. So the target has been 15% historically. And you can see for several years it was kind of at or just above that. Then it started going up from 2018 onwards. But really that increase has accelerated since COVID. And again, now it's at over 40% of people waiting more than 2 months to start cancer treatment. And so really, on some really basic measures, the NHS is struggling. And in the context of, the ongoing strikes, we also have to think about, it's not just about capacity. The NHS, a lot of it is its staff, and the UK has a retention problem. This is from an article today that came out in the FT with John Burn-Murdoch, and he's saying, 1 in 7 UK trained doctors has left to practice in another country. And the bad news is it's been going up, and it's also far, far higher than other kind of neighbouring countries. And so we're kind of saying that the UK does seem to have a unique issue here in that we can't keep hold of our medical staff. Part of that is pay. I do think this is just worth showing. This is how pay has changed in real terms, adjusted for inflation, since 2009. Everybody is kind of worse off on average than they were back in 2009, average payers. But you can see that decline is far higher for nurses and junior doctors than it is on average. And what that means is that actually, if you look at how much medical staff, nurses and doctors could get paid in other countries, that is now mostly higher than it is in the UK. So it's adding a significant pressure for staff to say, okay, actually, I could earn more in a different country, and is adding to the problem of retention and staff. But I do think it's important to acknowledge that when you ask people why they've left the NHS to practice elsewhere, money is not top. Top is things like dissatisfaction with the culture, burnout, work-related stress. And for some people, it is going home to where they were before. The NHS staff has been burnt out and stressed for years. COVID made that significantly worse. And the current backlogs and pressures and strikes and the way, you know, things are going is only going to make that worse. And I just want to kind of highlight that when there were the ambulance strikes earlier this year, they said, you know, the primary demand wasn't about just pay, it was about work-life balance and stress at work. Right, so moving on, I want to talk a little bit about wastewater. So this is a way of monitoring levels of COVID by looking at sewage effectively. And you sequence a bit of sewage and you see, can I spot COVID in there? Can I spot the virus in there? And it does work quite well. And many countries are following it, as are some UK nations. So this is the latest wastewater data from Scotland up to the middle of April this year. And you can see actually, this goes from this is the alpha wave in January 2021 up to now. And this is the ONS data, and I've kind of put it underneath to where this starts. And you can see it is capturing similar patterns, right? So this is the big BA2 Omicron wave in March, that's matching this. This is the July Omicron wave matching this. And here, this is the December wave we had in Scotland, which is shown here. So you can see that actually it does seem to be corresponding to the levels of infection in the community. And it's a useful way kind of keeping track of how much virus there is. Wales is also continuing with wastewater monitoring. This is the graph from their PDF of their weekly report, starting from November last year. So it's a shorter timescale being shown in Scotland. And this is the kind of equivalent period on ONS. And again, it's capturing this winter wave, and there's nothing really been happening since, which kind of also matches ONS. So again, it's showing you that actually wastewater does seem to be an indicator of prevalence. And so you might ask, well, you know, as far as I can tell, Northern Ireland has never done it, or I couldn't find any information from Northern Ireland. So what about England? Well, England did do it, but it ended in March 2022. It did say it could be really important, and we're exploring further opportunities for it, but they're not doing it. The publications aren't being discontinued. So I kind of think this is a real shame that if Wales and Scotland can do it, I'm not quite sure why we can't do it in England. And the other nice thing about the English monitoring program is that they used it to look at variants. And they looked at it quite successfully. This is December 2022 when Omicron came. You can see the rapid increase in Omicron viral sampling here. And in March, this is just when they switched it off, it also managed to track the really quick increase of Omicron BA2. So I think, you know, given that we're now doing hardly any PCR tests and are really finding it difficult to track variants using testing, this would be another way of tracking variants, but we're not doing it. And speaking of variants, the UK HSA published its last routine variant update report this week. So I just want to cover what that shows. It's quite a busy plot. So this is all the different colors are different variants. This is time on the x-axis, and this is the proportion of sequences there are. So we're here. So all of these colors, from the pink up to the yellow, are a subvariant of Omicron called XBB, and there are lots of different types. The most common type in England is XBB.1.5, and that's what caused the most recent small wave in March. But growing are XBB 1.9, which is this blue one, and then this pink one. And this is XBB 1.16, or in the press, it's being called Arcturus. And there've been various articles about it. It's caused a really, really significant wave in India and is growing in many countries in the world, but it's still only 2.3% in this country. And what UKHSA have basically said is that, yes, it does show a modest advantage over XBB 1.5, as does this one, XBB 1.9.2. It is in all regions except the northeast of England. Well, it probably is there, but it just hasn't been spotted because of reduced testing. But it seems to be unlikely that there'll be more than a modest wave. And that's mainly because we've had a wave of this one. And the thinking seems to be that this one isn't different enough to really make a big dent, given we've had a wave of that. And India didn't have a wave of this. Now, this could be wrong. There's still very, very few samples because we're not testing. So it could be that actually the growth rate is significantly higher than is currently being measured. And so we could still have a significant wave. But at the moment, the indications are that we won't. So I also want to highlight a report that came out from ONS this week, which looks at, and it comes out once a year, and it looks at work absence over the previous year. So this is the work absence for sickness in 2022. It was in the news, so you might have seen it already, but basically the sickness absence rate has gone up significantly. This is 2020, 2021, 2022, and it's now higher than it has been at any time since 2004. Now, in 2020 and 2021, there was a special category for sickness absence due to COVID. They've now got rid of that. So COVID gets recorded kind of under other, or potentially under minor illnesses if someone hasn't tested and they have COVID. So it's harder to kind of disaggregate it. But this is what kind of it looks like for why people are off sick. So highest is minor illnesses. And then there's other, including COVID. So that's kind of 24%. Now, pre-pandemic, it was at about 14%. So it looks as if quite a significant amount of this is COVID and still driving quite a lot of workplace sickness absence, which is obviously not great for employees or businesses and certainly not great for our economy. And that increase in sickness has been seen across every age group. This is through the years. So orange is 2022. And the highest in this kind of age range of 50 to 64, which also incidentally happens to be the age range where you have the highest rates of long COVID as well. And if we look at the work sectors where sickness is highest and the increases have been really high, it is in things like health and social work, education, accommodation and food services, basically areas where there's a lot of exposure to lots of other people, particularly people who might be infected. And so we can't just kind of assume that there's no consequence to specific industries, particularly of not reducing the levels of COVID or other infections in the community. And just to finally say on this, not only are we seeing record sick leave, we do really have to think about the fact that in the UK, we have really, really low levels of minimum sick pay offered, which comes with obviously financial challenges for people who can't work because they're sick, but also acts as a big incentive for people to go to work when they're sick. So just to summarize, spring boosters are underway for the over 75s and immunocompromised. It looks as if we're on a downward trend right now in terms of infections, but there isn't actually so much data on it. The Arcturus variant, which you've seen in the news, is here and growing, but it is still only 2%, and it is quite slow growth at the moment. So unless that changes, I don't think it's going to cause a big wave. The NHS in general is still in a bad place. Scotland and Wales are continuing wastewater monitoring for COVID-19, and I think it is really helpful in being able to spot waves and seeing whether something's on the up or not, and potentially even, keeping track of variants. England stopped that wastewater monitoring in 2022. I think that's a real missed opportunity. And Northern Ireland doesn't seem to be doing it either. And then finally, 2022 saw the highest rate of workforce sickness in almost 20 years. And with that, I will hand back to Anthony.
Thank you, Christina. Brilliant, as always. Health, of course, is not political, is it? That was a joke. Right, let's hand over to Trish straight away. And we're going to talk about preparedness for future pandemics with our two guests. Trish.
Great, thanks a lot, Anthony. So yes, we're going to consider this topic for preparing for the next pandemic, which is in the news this week for a number of reasons. Just 2 days ago, the World Health Organization launched a new initiative with with a new acronym, PRET, nothing to do with pret-a-manger. PRET stands for Preparedness and Resilience for Emerging Threats. And we're going to put a link to that new WHO report, PRET, on the IndySage website if you'd like to look at it in more detail. It covers a lot of ground, but one key headline point is that it's saying we need to strengthen health systems so that they're ready for a range of different kinds of emerging pathogens, taking account of the mode of transmission of each of these different diseases. Now, the PRET report also talked about strengthening communities to try and avoid a repetition of those staggering inequalities that played out in the COVID-19 pandemic. Now, something else that's been happening, and now I've lost my crib sheet. Sorry, won't be a second. Now you know that I've been reading it out. There we are. The Rhodes Trust held a high-level summit 2 weeks ago called Creating a Positive Legacy from the Pandemic. And a number of eminent people were at that summit from the policy space and the global health space. And one of the questions they discussed at the Rhodes Summit was, as we move beyond the current pandemic, and I know we're still in it, what do we need to do to make sure we're ready for the next pandemic? And we've got two guests who were involved in that summit, who Anthony's briefly introduced already. They're Dr. Helene-Mari van der Westhuizen, who's a doctor based at the University of Oxford, working in global health and in TB prevention. And you probably know that TB, like COVID, is an airborne disease. And we've also got Dr. Tanvi, health services researcher, also from the University of Oxford, with particular interest in health inequalities. So, Helene-Mari, can I come to you first, please? I hope you're unmuted. When we speak about this term, pandemic preparedness, where do we start?
Thanks, Trish, and thanks for inviting me. So I think a good starting point is COVID-19, which has and continues to have a devastating impact on health globally. It has highlighted what essential infrastructure was missing. But, and there's a big but, it is very important to recognize that it could have been much worse. And so at the policy summit, Rasmus Hansen presented data that showed that the number of high-risk outbreaks globally is increasing. And for many of these viruses, we have no vaccines or treatment available. So a key point is that we should not be basing our future pandemic planning on another COVID-19 scenario. An example from the summit, some of the modeling showed that if we had a different virus instead of COVID-19, for example, a human-to-human avian influenza, this could have led to 15 times more deaths in the UK compared to what we saw during the COVID-19 pandemic. So we need to think very critically about the type of health infrastructure we need globally to identify these pathogens early, to share this information between countries and scale up the tools we need to respond comprehensively and equitably. Like we saw with countries like the UK, who used a flu model as preparation for COVID-19 and was underprepared, we need to move beyond thinking about a COVID-19 model.
Okay, that's very clear. Now, the Rhodes Summit came up with a new slogan, always on. So can you talk a bit more about this phrase, always on, and why you think that's so important in pandemic preparedness?
Yes, and so with always on, we actually trying to describe the opposite of what most countries did during the COVID-19 pandemic. So many pieces of important health infrastructure had to be built from scratch. And while many systems did eventually catch up with the surge in demand, time and lives were lost. So now also, as Christina was mentioning, we are seeing some of this infrastructure being dismantled. The always on approach suggests thinking about dual use. So we start by looking at what was critical for the COVID-19 pandemic, and then think which components would be helpful when providing routine healthcare so that we can continue to use them. This will enable us to have some of the important infrastructure ready to respond for the next global health crisis. And so at the summit, we spoke about how this idea can be applied to different topics, from pathogen surveillance to clinical research infrastructure to adult vaccination. And I'm going to give an example of adult vaccination because we know that the first important task is developing an effective vaccine against a new pandemic virus. but also making sure that we are able to deliver these vaccines to adults at scale globally is a massive challenge that many countries have struggled with. So there's an exciting new collaboration between researchers based in Scotland and Rwanda to learn from each other and look at bundles of adult vaccines as appropriate for the most significant diseases of each country. So this builds on the vaccination infrastructure that was created during the COVID-19 pandemic, but it's also an opportunity to consider adult vaccines that are currently underutilized and add in some of the new vaccines that are becoming available that draw on some of the innovations from the COVID-19 pandemic that could make a big difference to preventing disease and early death. So the key point is, by developing community-based adult vaccination infrastructure as part of routine care, we are able to quickly shift should a new pandemic hit.
That sounds like a great idea. Now, I noticed that just after the Rhodes Summit, there was quite a big spike in media attention around the pandemic and pandemic preparedness. And certainly some of us on Indie Sage were invited to go on the TV and the radio to talk about pandemics. And that was a sort of against a backdrop of loss of interest amongst the public and politicians. And they all sort of seemed to think, oh, well, I'm not going to do the pandemic anymore. So you did something right in terms of getting people interested again. Were there any suggestions or specific suggestions at the summit about how you maintain and raise interest?
Yes, and one specific focus was looking at how to also get political interest.
Okay.
And so one of our keynote speakers was the former Prime Minister of Great Britain and Northern Ireland, Tony Blair. And he advised us to do 3 things to get politicians to pay attention. So the first one is we need to make a case for immediate action. And so at the summit, there was also some modeling to look at, what does the future look like for new pandemics? And one of the modelers suggested that the chance of another COVID-19-like pandemic in the next 10 years can be as high as 27%. So this doesn't mean that COVID-19 is a once-in-a-lifetime event, but something that does need urgent and immediate action. And the second point that he advised is that we need to show that pandemic preparedness is politically popular. And so in preparation for the summit, and this is a component that did gain a lot of traction in the media, was we did polling with YouGov, and 59% of members from the UK public felt that United Kingdom politicians were not taking the risk of a future pandemic seriously enough. And 77% said that the government should do more to invest in their own healthcare system's ability to respond to a future pandemic. And we did similar polling in South Africa and in the United States. The third bit of advice that we got from Tony Blair was that we need to show that this investment can lead to long-term health benefits. And that's where the always-on component came in. So in summary, I think the risk of not preparing for a new pandemic is very clear. COVID-19 is not a once-in-a-lifetime event, and we need to prepare for a variety of potential outbreaks. There is public support and a unique opportunity to integrate our pandemic preparedness with strengthening existing care by using this always-on idea.
Oh, well, that sounds fantastic. I can't wait to kind of get to the discussion bit. So where we all kind of chip in and bring together what you've just said with that rather troubling data that Christina presented at the beginning about the state of the NHS in the UK. But before we do that, can I come to you now, Tanvi? You joined a panel at the Rhodes Summit about the role of public trust in science during pandemics. Now, we all know that trust has been a really hot topic in the COVID-19 pandemic, and trust covers a lot of different issues. So, Tanvi, what kind of expertise did you bring together on that panel to talk about trust?
Thank you, Trish, and thank you very much for inviting me to this meeting. So it was a multidisciplinary panel with experts from different fields, including journalism, civil society, international global health organizations, and myself as a researcher at a university.
Yeah, gosh, so the journalists are in there too. And when they talked about trust, you've got to have something to have trust in, haven't you? Trust in what?
So trust has many dimensions. It includes trust in data, in health systems, trust in past experiences of healthcare or interactions with healthcare workers, community trust, but also things that have happened in the past that might make people mistrust the government, or the institutions or science. And this makes it quite difficult to plan at a global level because there's so much local context that's relevant. But what was common across all of this is the need for trustworthiness.
Okay, so how do we raise our trustworthiness, if you like, in the eyes of communities who might have reason to mistrust us?
So transparency is important, and what influenced public trust in pandemic policy was a perceived disconnect between science and policy, with scientists saying one thing and policy appearing out of step with that. For example, when scientists are saying the virus is airborne and spread by inhalation, but the policymakers are focusing exclusively on washing hands, without doing anything to improve the quality of indoor air. So that's one example. There was also a breakdown in health communication and trust in policy recommendations when these were removed from local context. An important example was that, in many places, people were being told to quarantine or not go to work. But local realities meant that they needed financial support to do so, and there wasn't any social security to enable them to follow the guidelines.
Okay, now this sounds like it explains some of the inequalities that we saw in the pandemic.
Yes, the pandemic exposed and exacerbated inequalities that run through all health issues, not just COVID. It also exposed how health inequalities are related to inequalities in many other areas, such as housing, employment, education, and so on.
Okay, thanks, Tanvi. So are there global examples of strategies that could be used to support public trust that you feel that UK policymakers should give greater attention to?
So firstly, Bekasisa is a Centre for Health Journalism in South Africa, and there was a representative from there, in fact, the founder. She emphasized at the summit that consistency is the currency of trust. It is very important to partner with the media and support them to provide accurate information that is easily understandable. Secondly, there is a need to communicate with the full range of people and groups quickly and effectively. For example, by using social media and the many different formats of media that people use daily. Partnership with civil society, community and grassroots organizations can help reach a much wider audience. And also that peer-to-peer communication is a very important but very underutilized tool. Thirdly, we need to take a historically informed and contextually grounded approach to addressing mistrust. For example, we need to be humble and honest about past and present histories of medical abuses and poor behavior and how that might play into people's mistrust today. And finally, to build trust in pandemic policy, it's important to collaborate and bring together expertise from all sectors. So companies, governments, university researchers, local community groups and leaders.
Okay, Tanvi, thanks for that. Now, you're an expert in health inequalities. I know that some immigrant and minority ethnic groups in particular fared very badly in the last pandemic. Based on your research in the UK on health inequalities, how can we make sure we don't make the same mistakes next time?
I feel like we need very sensitive and careful planning in public health communication. The media narratives that we had and the rhetorics that even politicians were using really pathologized people who already are socially marginalized in this country. And they used what you might call deficit-based explanations, which in other words means that it focused on what certain people either didn't have or didn't do. And they used terms such as race and ethnicity in, categorizations of race and ethnicity in very problematic ways. They were either, for example, using biology or culture to explain disparities when it was actually due to long-standing structural inequities. For example, implying that South Asians, such as, Pakistanis and Bangladeshi people had worse outcomes in COVID because they were genetically predisposed to do so, rather than taking into account the fact that many of these people, needed to travel for work on public transport, and they were working in busy indoor settings where they were much more likely to be exposed to COVID. We need to publicly acknowledge racism and discrimination in healthcare, both past and present, and how that might affect people's attitudes towards health policy, especially when there's a crisis. And they are very extreme measures that seem to be forced onto people. And finally, I think we need to provide realistic and equitable social security measures to empower people enough that they want to and can follow guidance. People don't make decisions about health in a vacuum. They're very much influenced by where they are situated in UK society and what else is going on in their lives. For example, are they economically secure? Do they have caring responsibilities? Are they struggling to find a job? Have they been profiled by the police? Have they got welfare or immigration troubles? Are they being subject to racism or discrimination in their daily lives? And all of that will impact on how they act and how they respond to policy and guidance during a pandemic as well.
Wow, well, thank you very much for those comments on health inequalities, Tanvi. And can I thank you and Helene-Mari for joining us today. Don't go away. I'm now going to hand back to Anthony as the chair, and I'm sure he's going to bring the discussion round and involve other members of Independent Sage, and then we're going to take some questions from the public. Back to you, Anthony. You're muted.
Oh, yeah. Sorry. Thanks very much, Trish. That was great discussion. And I mean, this whole misinformation, disinformation thing has really gathered steam because of social media, but also because, you know, in the United States, we've seen Fox News having to pay almost $1 billion in fines for spreading misinformation about the US election last time. But every day in some of our major media newspapers and even online sources, they're putting out misinformation. And then, of course, there's disinformation, including by doctors who are making money out of spreading anti-vaccination materials and the like. I mean, this is a big challenge for us. And I know I've just been at the WHO, and they're very worried about the overall effect on, for example, vaccinations amongst children, that, you know, people are out there developing all kinds of fantasies about the threats from vaccines and the like, which are out of all proportion to their risks and benefits. So it is a really big problem, isn't it?
Can I come back here, Anthony? Because I think it's, I mean, you mentioned Fox News, and it's quite easy to demonize the media, isn't it? But I think remembering back to what Tanvi was talking about is what we need is partnerships with the media, with responsible journalists, but also to tap into the skills of media people who, you know, they're experts in communicating. And I was working recently with Alma de Graaf-Akins, who's a professor of global health. She's based at UCL now, but she actually worked, she's from Ghana originally, and she studied the media in Ghana, and she's looked at how the local newspapers, the local radio stations, cartoonists, and also stand-up comedians became part of the effort to educate people and engage people at local level in the early months of the pandemic, where there wasn't a lot of misinformation and just gaps in information. But actually, because the media took their responsibility seriously, they did it in a way that was very engaging, and particularly the jokes and the songs and the dances were all part of that engagement. So I think although there is bad media around, there's media who are very irresponsible, but I think I was very struck by what Tanvi was saying about the media being our partners. I don't know whether you want to comment any more on that, Tanvi.
Yeah, sure. I think apart from, you know, the importance of actually talking to the media and communicating science in very easy to understand smaller chunks so that it's accessible to the general public, there's also a sort of further upstream issue to address, which is that science is not exact. You know, so there might be kind of more epistemological problem whereby belief and misinformation sometimes you can have extreme kind of views because it allows you to that, because it's not based on evidence. So I think even like engaging with the media is important, but also to start with an explanation of how vaccines are not 100%, and that's normal, that's not new, and sort of like allow space to really properly educate the public. And there is hope, because a lot of people started talking about R-naughts during the early stages of the pandemic, which was quite surprising. People you wouldn't expect. And I was thinking, oh, let me remember from my public health masters what R-naught was. But you know, there were people
What is R-naught?
Kitchen table. Oh, the transmission, how many people you're likely to have, you know, per infection.
Oh, R-naught. I thought you said R-naught. Well, it's a biscuit.
Sorry, R-naught. Yeah.
No, it's me. R-naught. Oh, yeah, I had trouble with that one for a long time. Yeah. But in fact, it was the media that explained it. It was journalists who made me understand it. There we go.
Any other questions from our panel before we go on to, because there's some good questions from the, yeah, Steve.
Hi, just thank you both, guests, absolutely brilliant. I just had a feeling, just a question around, you know, it's the government and agencies have done preparedness exercises, you know, so, and even including exercises involving the outbreak of a coronavirus, for example. So the problem is that a lot of those recommendations from those exercises haven't actually been carried through into, you know, into policies or into strengthening our healthcare system. So is anyone looking at that and how we can sort of persuade politicians to actually take those recommendations seriously and implement them, so we don't have panics around PPE and whatnot, and testing and tracing and that sort of thing? I mean, it really does sound like, you know, and even getting that information to our advisory panels like SAGE seem to have been problematic. So I just wondered if there any discussion of that at the forum.
I think so. Some of the comments were that the general feeling of the approach to pandemic preparedness has been this oscillation between absolute panic and neglect. And so I think there was a lot of discussion about how you can find a constructive middle way where you're trying to build into your routine ways of doing what you would need in future. And so I would almost, drawing on that concept, to say, like, what are sort of routine touch points that could be strengthened, so relationships that could be built, collaborations that could be set up, that is not just there for a pandemic, but that can sort of strengthen the way that communication happens as a routine. Yeah, so that was sort of the appeal of drawing on always on. Just also wanted to touch on earlier when we were speaking about misinformation, and I think at the summit there was several comments that's saying that the misinformation around vaccines has had a spillover effect from predominantly sort of focusing on COVID-19, but to other routine childhood vaccinations and adult vaccinations. So when we're speaking about strengthening adult vaccination infrastructure, it's not an easy task, and it will need to engage with sort of community perceptions and like Tanvi mentioned, sort of the slow process of building trust.
Thanks.
Let me chuck in a couple of questions here from our public. So the first one is from Janice Plant, and she said, how can we prepare for the next pandemic when seemingly 99% of the population aren't behaving as if they're in the current one? First, people need to accept they're in a pandemic rather than be in denial, don't they? How can we deal with something many people don't believe exists? Anyone like to pick up on that? I mean, this is, again, where politics comes in, isn't it? Because there was a decision taken almost exactly 2 years ago when we had so-called Freedom Day by our banker health secretary, Sajid Javid, who decided the pandemic was over and that was it. So now, politically, there may have been reasons to want to do that in various ways, but it did lead to a lot of actions that eventually meant that another, you know, however many tens of thousands of people died. And that's one of the great struggles with public health. How do you balance that against other political and economic concerns? Any other comments? Trish?
Yeah, then in response to that question, which is very relevant to our topic, but also quite provocative. There's some work going on, again, here at the University of Oxford, but also linking with other universities. It's led by, it's not led by, but one of the key people involved is Erica Charters, And she's got a thing about how do pandemics end. They're doing a piece of research funded by, I think, Wellcome Trust on that. And the idea is that pandemic begins when someone from the WHO gets up and declares it to be a pandemic. And, you know, on the 11th of March 2020, that happened and the pandemic was declared. But actually, nobody undeclares a pandemic. And what this piece of work that Eric has been involved in says pandemics end when we all get bored with hearing about them, when the media don't cover them anymore, and when people think other things are more topical and more newsworthy. Yeah. And so although they begin with a bang, they tend to end with a whimper. But as we are currently seeing, there's still an awful lot of deaths, there's still an awful lot of sickness, both acute sickness and ongoing sickness, but nobody's interested in it anymore. And I very much liked what Helene-Mari was saying, you know, quoting Tony Blair, that hang on a minute, we've got to get politicians interested and we've got to get to kind of keep it topical, and also to say there are long-term benefits from attending to this. I was quite interested in the link between that and something like air quality, that if we can get the politicians interested, if we can get the public interested, we can then say, let's improve ventilation, let's improve, make it safe to be able to go into a building, whether someone's breathing out SARS-CoV-2 or not.
Thanks, Trish. We got a couple more comments. I know Christina wants to say something, and Aris also. Christina.
Yeah, actually, just following on directly from what Trish was saying, is that a lot of the always on approach comes with public health benefit. And I think we have to start recognizing that the things we need to do to create a healthier and more resilient population and country are things that benefit our health, our well-being, our economy, our environment, employment, all of it. So thinking a little bit more connectedly across all policies, not just pandemic preparedness and health, will be beneficial. And we're just not, well, most countries aren't very good at that, but we're certainly not very good at that. We're very siloed.
Absolutely.
Professor Aris.
Oh yeah, go on.
Yeah, just a brief comment in that, you know, there's no rule saying that you can only ever have one pandemic at a time, right? So whether or not there are people acting as though the current pandemic is over doesn't mean that we can't have another pandemic or even a couple sitting on top. And we've already have people really concerned about, you know, the possibility of avian flu transmission and all sorts of other viral threats. And I don't think you can say that whatever you think of how well scientists have succeeded, we've had a pretty good stab at raising awareness with regards to the current pandemic. And the reality is that it is the fear of future pandemics and the reality of the possibility of future pandemics that will drive further innovation and further preparedness for what is a very real threat.
Yeah, and 200,000 people dead or more is 3 times the numbers that died in the Blitz in the Second World War. So, I mean, we're talking about a big... can I bring in the next question, because it's linked to this? It's from Raj Tamadoran. Taking everything into account, is the UK better or worse prepared for the next pandemic? Who would like to comment on that? I mean, there's a social and political side to this, and there's a scientific side to this as well. Anyone want to? Christina has her hand up, and Helen Salisbury. Christina.
So just on whether we're better or worse prepared. Yeah. Well, I think in terms of surveillance and being able to set up surveillance, we're better prepared. In terms of actually dealing with it, much worse. The NHS and the economy are in much worse positions than they were in 2019. And that's going to really hamper what we can do. And actually the trust issue is gone. I think because we've made some of the pandemic into a culture war, things like masks and vaccines, it actually means that we're less able to respond as a population, I think, for the next pandemic. And that really worries me, because in an infectious disease, you kind of need everybody to believe it's there and to act accordingly. And it's not something that an individual can do on their own.
Helen.
I was only going to say that on a more cheerful note, that kind of some of us vaguely know what to do now. When the next time we've got to immunize everyone really quickly, we know we can do that. We can get there. Actually, general practice stepped up amazingly and got stuff done in terms of vaccination. So in some ways, we have practice now and we're better at it. But I totally get that we're in a worse starting point in terms of public trust and general health of the nation.
Yeah, and I think there were systems failures right at the beginning, which are still with us, that we didn't have the systems in place to really think about ways of suppressing this virus quickly and what they did in East Asia. Now, whether next time we're going to have built a pandemic advisory group of people that are going to really look at this in detail and come up with the kind of tools and guidelines that they had in East Asia, I hope that will happen, because the East Asia did have the advantage of having been through SARS and MERS, and therefore they were paranoid about it. I hope that there is sufficient paranoia in this country politically to really deal with the immediate effects, the immediate response, because it's so important to act quickly in a pandemic. Anyway, sorry, did anyone, was that Steve? Did you?
No, Sheena.
I beg your pardon, Sheena, I didn't see, yeah, Sheena.
I just also wanted to chip in with a slightly more positive take that although we've talked about the real issues with public trust, I think one of the positive aspects is the way that we have learned to really kind of speed up vaccine trials. We've innovated vaccines, we've innovated medicines, we've innovated tests. And all that knowledge, I think, will help us, and all those platforms will help us be much more rapid and responsive should it happen again.
But our health service is in such a mess.
Mm.
And that's a more systemic and political issue, I think, that we need to. Can I just come on to, Steve, yes, Steve Griffin.
Sorry, can I just say one very quick thing about therapeutics? Because we have this amazing advance in vaccines, but it was very obvious that when SARS-CoV-2 hit that we didn't have the antiviral drugs to treat it properly. We had one or two hanging around that we understood should work, and remdesivir did work when we started using it properly. We've finally seen some more made. And the reason for this is that governments just aren't really investing enough in this sort of technology, and we're leaving it to pharmaceutical companies who, if they have a cost model and they have to recoup their money, means they're not going to invest in these neglected tropical diseases that may or may not jump across. So I'd really advocate that we need to do better in investing in that sort of thing, because an antiviral is quicker than a vaccine. If you've already got it, it can stop that initial breakout, and it can stop that initial severe disease. So if we had those sorts of things ready for the next one, then that would stand us in really good stead. And I'd really love to see governments getting together on that in the way that they're trying to do with vaccines.
Well, yeah, wealthy people will get it, but in low-income countries, less than 30% of people have had a vaccine.
Sure.
And that's because all the companies are making hundreds of billions of dollars, and there's no waiver of any patents. The whole thing is a neoliberal mess of immunization. Exactly. Sorry, Trisha's got a finger up.
Yeah, sorry, I've just had, while we've been on air, I've had a message from someone pointing out that the original WHO PRET report was not published 2 days ago, it was published a year and 2 days ago. And the excitement a couple of days ago was people saying it's the first anniversary. But what has happened recently is that there's been a number of sub-reports giving depth and detail on those original goals set a year ago, and we're going to put both the original report and one or two of the more recent reports on the IndieSage website if you want to look at them. So sorry, I got that wrong at the beginning, but I'm sure you'll work it out on the website.
All right. I've got two vaccine questions, which are quite interesting. So one is it a viable strategy to get a booster every 6 months until we have a better understanding of therapeutics against, drugs against long COVID? Or are there any known downsides to such a course of action? I am 45 years old. That's not me. This is him. That is. I am 45 years old and have so far tolerated all my COVID shots quite well. Here in Germany, I will be able to receive further boosters at low or nominal cost. The issue is, am I overlooking something? Can you get boosted too much? Anyone? Sheena, you're our immunologist.
This is a really interesting question. I mean, I think I think that I read something quite recently that was discussing the timing of the boosters, which currently are all that we really have. And it was sort of suggesting that when you look at the dynamics of the antibody response, and the way that we sort of stay protected from severe disease, that what you could do is start thinking about, you know, when you're going to be doing things. So if, for example, you've got an important holiday with your family in a couple of months' time, you might want to just delay the booster a little bit to be close to that, particularly if you were quite close to your last booster, because then you're sort of keeping your levels as topped up as well as you can. So it's worth considering how recently, say, you were infected or how recently your booster was, to sort of factor in those things. But these are very personal decisions. The British Society for Immunology has just put out a statement and a big policy briefing that is really making the case for doing more studies to assess markers and indicators of vaccine efficacy in the context of COVID. And a lot of US has also been looking at greater investment in longer term vaccines. I haven't seen the same move here in the UK. I really do think that we do need to be moving to longer term vaccines that will provide us a more robust protection and not require these booster top-ups.
Yeah, that's a good point. Helene-Mari, you were going to come in, you know, earlier we were talking about the sort of global inequity in access to vaccines and research and the like. You were going to say something about this.
Yeah, I just wanted to make a comment about sort of the global nature of a pandemic and how we need to look at clinical research infrastructure, not just within the UK and other high-income countries, but also how we can strengthen sort of the global pandemic response, and looking at investing in setting up infrastructure to do clinical trials for vaccinations, for diagnostics, for therapeutics, and not just in the high-income countries is really important. So if we look at how many trials are done globally, only about 2% of clinical trials are done in Africa as a continent. So I think just there's a large gap that we need to start investing in so that we can be better prepared across the world.
No, that's a very good point. Although there are increasing networks around the world that can do quite large trials. And of course, I mean, it all does come back to money, that people knew they were going to make hundreds of billions of dollars. Shareholders, politicians all got behind them and blocked the ability to spread vaccines around the world. And, you know, Gordon Brown called it a global disaster. And I think he's right. I think, you know, I got a polio vaccine when I was 7. Because it was patent free and it was spread around the world very quickly. Anyway, that's right. One more on vaccines. Sorry. Given that vaccination provides strong protection against death in the acute phase of infection, the possibility of post-acute sequelae, longer term consequences, now seems like a central threat, long COVID. And Christina's data presented earlier about people being off work, both for individuals and for our societies. Earlier in the pandemic, research indicated that 30% of COVID cases resulted in ongoing health issues. More recently, I've seen an estimate of 10%. Do we know whether these figures hold for the current phase of the pandemic, in which many of those in wealthy countries are vaccinated? Is there recent research that breaks down the risk of these longer-term effects by vaccination status, including 3, 4, or 5 jabs? So it's you know, long COVID. How much is it reduced by vaccines and the number of vaccines you have? Anyone on that? Duncan or Christina or Steve? Or Steve's got his hand up.
Well, we do know about long COVID, as in the sort of the classical long COVID, if you like, the lethargy, the heart problems, the breathing problems, that sort of thing. We know that vaccines will provide some protection from that. The studies vary, but you're looking at sort of a 50% reduction. Seems to be less certain about that in children, although there does seem to be evidence of it. And that was all based on an ONS study that was out a few months ago. I think Christina presented those data a while ago. So that's really important. But I think as a general principle, if you are vaccinated, if you have been recently vaccinated, you're less likely to be infected or reinfected. And so therefore, and even hopefully have less likely to have a more severe clinical course. So all of those things will contribute to less risk of ongoing health problems. And we know that as well as the sort of classic long COVID symptom cluster, there's problems with our cardiovascular systems, the metabolic problems, neurological problems. So really, it's about not exposing yourself. And if vaccines prevent exposure and prevents severity at least, then there should go some way to reducing that. But I think there are massive population scale studies going on. There is some debate around that. There was a recent study from Denmark showing that the diabetes question was being questioned. There's some different data to other bigger studies. But I think we need to really look long term. It was certainly the case that after the 1918-19 influenza pandemic, there were issues with cardiovascular health, etc., going on for about a decade at least.
Yeah, well, even longer with, encephalitis and stuff. Any other final comments? I don't see any other hands up. We are actually just over time. So I just want to thank everyone on the panel, particularly Helene-Mari and Tanvi. Thank you so much. We'll have to get you back, don't worry, because these are really important issues for the future, for the public inquiry, for our politicians, and the whole issue of pandemic preparedness, which is just as important as preparing defense for other things against a military attack or climate change. So thanks very much. We will be back in 2 weeks' time, same place. Till then, keep safe, and thank you very much for joining us.